about now? There we go. So we'll start over. So with diagnostics, the key thing to remember about diagnostic procedures is that all we're doing is just looking. We're trying to get a better picture of what's going on with that patient specifically. Once we determine that, then we can decide whether we're going to remove something, if we're going to repair something, if we're going to, just make an opening, that kind of thing. And diagnostic procedures can be invasive or non-invasive. They can go either way. It's all dependent upon are we just looking for something, or are we actually planning on doing something. So as we get into these, you'll see. So that it's that initial step, more like professional definition of it is that initial step in medical or surgical decision making. Right, this is us deciding what we're going to do based on what we find from the diagnostic test. Right, we're trying to evaluate that patient's condition. How are they doing? Right, we start that off with a history of the patient, their medical history. Right, have they had any broken bones? Have they ever had surgery before? What kind of disease processes do we have? Right, do they have diabetes? Do they have COPD? All these. That's the history we're getting. Then we do a physical exam of the patient. Right, we look them over. If they're talking about right lower quadrant pain, right, we're going to do a physical exam, but actually put hands on the patient, and the doctor is the one who's doing the exam, right, because they've been trained on what to look for, things like that. And then you can have invasive and non-invasive, like I was saying. So non-invasive type stuff, and we'll get into it here in one of these slides. But that's like, X-ray, MRI, CT scan, ultrasound, getting the history, right? The physical exam. We're not actually breaking skin or going into the patient, right? We're taking pictures through them. Invasive type procedures would be like an EGD, right? An esophagoscopy, a colonoscopy, an exploratory laparotomy. It's invasive, right? We're cutting into the patient, but just in the name, exploratory laparotomy, all that says is we're making an incision into the abdomen to explore, to look around. So if you ever see a case that's booked as just an exploratory laparotomy, that in and of itself is just a diagnostic procedure. So normally what you're going to see is exploratory laparotomy with possible bowel resection or possible appendectomy, possible cholecystectomy, possible splenectomy, right? Those kinds of things. Or it'll be exploratory laparotomy, with liver laceration, right? Okay, we're going into the abdomen, we're making a big open incision, but we're going to go in and repair that liver laceration. That makes it no longer diagnostic. If it says possible and you go in and you don't do any of those possible things, it was just a diagnostic procedure. What we're talking about here is pathology, right? The study of disease. That's why we do all of these diagnostic type things, as we're trying to find out what disease the patient has, what's the problem, and all of these tests can lead us to what we need to, give us the information we need to know so we can find that disease process that's going on in that patient. And then now we know how to treat that disease. But some things to understand about pathology, some words to kind of wrap your head around, are things like etiology. That's like the study of its origin, right? Where did that disease come from? Idiopathic, that's the path, right? That's the way that the disease got into that patient, what it's doing to that patient, right? What it's destroying, all that kind of things. How does that disease work? What does it do to the body, right? Mortality and morbidity, these are like your death rates, right? How bad is it, right? If a patient gets it, a certain disease, what's the likelihood of them dying? Pathogenesis, this is another, so genesis being like the beginning or the origin, patho being disease. So the origin of the disease. Where did it come from? Right? Signs and symptoms. So these are always coupled together, but they're not the same thing. Right? A symptom is directly related to that disease. It's actually something physically that is happening to you. Make sure I said that right. Yes. So something that is physically happening to you. Right? You got a runny nose, itchy throat, pain in the abdomen, right? Those are all symptoms. Right. Yes. And then a sign, for some reason I think I have these reversed. Let me look back on some of my old notes and we'll come back to that. Complication. A complication is where you did the technique of your surgery right, but there's just sometimes a problem that occurs. Right, those are your complications, like a complication of surgery, something like that. Right, where one of always the big complications of surgery or potential complications of surgery is bleeding, post-op bleeding. Right? Sometimes you don't get all of the vessels tied off or whatever. They're really tiny ones that you thought when you irrigated and closed up, you didn't see any bleeding, but the patient got over to recovery. They were waking up and they kind of strained something or whatever and caused some bleeding to start up. Complications. Exacerbation means to make something worse. Usually, when we're talking about diseases, one of the examples I can bring is if anyone's ever had to deal with their gallbladder being bad. Right? You exacerbate that pain from your gallbladder by eating really greasy, fatty foods, because now you're kicking that gallbladder on, and it's got to expel the bile. But whatever you got going on with the gallbladder that's causing pain is now going to be even worse because it's now come online and started trying to do what it's supposed to do, even though it's kind of broken. Syndromes, these are like disease processes that are genetically related. That's why it's a syndrome. It's not something that they can like give you medicine for, or a shot or a vaccine or something like that, and it takes it away. Prognosis. This is your future diagnosis. How well are you going to do as the patient after whatever procedure? Right? We brought you in and had your appendix taken out. You should be fine after that. We came in and you had a traumatic amputation of one of your legs. Well, your prognosis in the future may, yes, you're going to recover from that and everything will be fine related to that, but there may be other things that go along with that long term. Right? Remission, this is in reference to cancer. This is when you have cancer and then you get treated, whether it be surgical removal or get like radiation or chemotherapy treatments or something like that, and then now they test you and all of your cancer is gone, or at least it's not showing up on the test. Now you're in remission of cancer. Relapse, cancers come back. Right? You had it, we got rid of it, it was all gone, you were in remission, now it's returned. So you relapsed. Terminal means death. That if a patient is terminally ill, that means whatever disease process that's making them sick, it's going to kill them. We're not going to be able to. We may be able to do treatments in terms of like kind of a hospice style, making them comfortable and things like that. But no treatment that we're going to do is going to cure that patient, and they're going to end up dying of that disease. Curative and palliative. Curative is, and whenever you see the tiv on the end, this is in reference to something else. So we're talking about like curative procedures. This is, again, like with the cancer, going in and taking out like a lump of cancer, and then now the patient is cancer-free. Right? Well, they were having an appendicitis. We go in and we take the appendix out. Curative, right? We've cured them of the appendicitis because now they don't have the appendix to be inflamed anymore. A lot of surgery is curative in that regard. You have a obstruction in your bowel. We go in and remove the obstruction, reconnect the bowel. You're cured now of that obstruction. Palliative, this is just kind of like, making them comfortable, walking them through. We know we're not going to cure them of their disease process, but we're trying to make it the most comfortable we can for the amount of time that they have left. Vital signs. We did these in the lab, right? Temperature. There's a few different places on the body that you can take the temperature. You can do an oral temperature. You can do axillary in the armpit. That's typically when at home is where you take the temperature of your baby. Right? In the hospital, they're typically going to take the temperature of infants and stuff rectally. That's the most accurate. They try not to do it orally because the baby's going to fight it. Right? They don't want something shoved in their mouth. They don't know what's going on. You can't really explain it to them. You can do the temporal. You've seen the probes right at the hospitals and the cameras and stuff we have on campus. So oral, axillary, rectal, and temporal. Yes. Your pulse and your normal temperature range is anywhere from about 96 degrees Fahrenheit, 95.7, I think it is, up to about 99, I think, 99.1. You're within normal range. Usually something around 99 may bring some question as to, are you having a fever? If you live down around 96, then 99 is probably a fever for you. If you live around, 98.8, something like that, 99 is probably not a fever for you. So your pulse, typical range, healthy range is anywhere from about 50 beats per minute to 80 or 75-ish, right in that range. Anything over that, and you're looking at tachycardia or fast heartbeat. Right? I say 50. 50 might even seem a little low. It depends on the health of that patient. Right? If you've got a patient who, it's basically a sedentary lifestyle, they have a BMI in the 30s, they're overweight, that kind of stuff, that low of a pulse, there's a problem. But if you have somebody who's, a marathon runner and, they run, 10 to 12 miles a day, things like that, they're going to have a really low resting heart rate. So there's some other clues to take in. And if it's too low of a heart rate, that's bradycardia. Right? Tachycardia is fast heartbeat, bradycardia slow. Places that you can take the pulse, you've got your carotid pulse in your neck. Right? You have the brachial pulse in next to your bicep in your upper arm. You have the radial pulse down just below your thumb and your wrist on the anterior side. You have your femoral pulse right in your groin, your popliteal pulse behind your knee, and then your pedal pulse on the top of your foot. So in any one of those locations, the pulse can be taken. Respirations. Typically in the OR, we monitor this with that pulse oximeter. But if you ever have to do like a respiration assessment on a patient, you never want to tell them that you're counting their breathing, because subconsciously and consciously they know that you're doing that, and breathing will change just because you feel that somebody's watching you and you're trying to like do it perfect. And sometimes you take shallower breaths or deeper breaths and things like that. It's going to throw off the normal respirations number. Typically, you're going to count your respirations at the same time you're doing your pulse, because the pulse is not something that they can really change that drastically, and they're focused on you touching and feeling for that pulse. And for the first 30 seconds, you count your pulse, and then for the last 30 seconds, you're counting respirations, and then you're multiplying both numbers by 2 to get how many per minute. And then your blood pressure. We did that in the lab too with the sphygmomanometer, right? The blood pressure cuff. If you're doing it manually, like we did in the lab, you have to have the stethoscope, because you should be listening for the pulse right in the antecubital, or the inside part of your elbow. That's the antecubital space. That's where you're listening for that pulse to return. Remember, your whatever number you're watching on the dial, as soon as you first hear the pulse, you're looking at those numbers and you're recording that number. And that's your top number, the diastolic. And then you're listening. And then when you don't hear the pulse anymore, the last time you hear the pulse, you remember what number the gauge said. That's now your systolic, or the bottom number. And then there's your blood pressure. Right, you got the top over the bottom. Good to go. Temperature conversions. You definitely need to know this. Just memorize one of the equations, and then you can always figure out the other one. If, like, let's say I gave you only knew the lower equation, the Fahrenheit equals the 9/5 times your degrees in Celsius plus 32. And I give you the temperature of, say, 212 degrees Fahrenheit. Well, you're just going to work backwards. You put the 212 degrees in where the F is, and then solve for C. And you should get an answer of 100 degrees Celsius. But no matter which one you memorize, just memorize one of them, whichever one you like better, and know that, because you will see questions on your CST exam about converting in your temperatures, converting in your weights, right? Pounds and kilograms, ounces and milliliters or cc's. These are all fair game because they're part of your pharmacology questions. And a lot of temperature questions come and are they revolve around malignant hypothermia with anesthesia. There may even be a question as to you need to figure out what the temperature is and then determine whether or not the patient is actually having a malignant hypothermia event or not, depending on their temperature. So memorize one of these, or both if you like. The places, so yeah, oral, tympanic, that's that temporal, rectal, axillary. You can also touch just the patient's skin, or just even look at it. If they look all sweaty, they're probably hot. Right? If they look like clammy, stuff like that. Sometimes when you touch them, especially a patient who's expired in the OR, if you have to help move them to the morgue or something like that, you're never quite ready for how cold the body actually gets after death. Strange. And you can feel it through the glove too. You're just like, wow, that's really cold. And then whenever we document temperatures, we always record them in Celsius, which is another reason why we need to know those conversions. A lot of our instrument, a lot of the instrumentation or the equipment is going to display it in Celsius. So it makes it easier for us to document it, but sometimes we're going to get it in Fahrenheit and we need to know how to convert. And in some of these places, the reason there's so many different places is usually your tympanic and your rectal temperatures are going to be anywhere from about a half degree to a full degree higher than your oral temperature. And this can be any number of reasons. Maybe you just drank something cold. It could even be higher. That this is the problem with the oral is that if you just drank, say, like some hot coffee, or you had a cold soda or something like that, then it's going to affect the temperature reading on that on the thermometer. So, and then your axillary temperatures are typically your lowest readings because you're just getting, up underneath the armpit. You're not actually getting in the body. Pulse, when measuring pulses, sometimes they have to be documented. And this is how they document these number systems. So if you have a 2+, that's a normal, right? You can feel a good pulse. You can feel it going through. If it's weak and you're feeling it come through, but it's like a real light. You're not feeling that boom, 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 right? That's a weak pulse. If you can't feel it at all, then it's absent. Bounding would be that you don't even really have to put any pressure on that. You could probably just look and you can see the vessel itself just by looking at the skin. Boom, 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 beating real hard. That's bounding. It could mean, that bounding kind of pulse could mean the heart's working too hard. It's pushing too much. Right? And then we always document it in beats per minute. So the number we put down is beats per minute. And then when actually taking a pulse, what you do is with two fingers, typically your pointer and your middle finger. You never use your thumb to measure a pulse because your thumb has an artery in it. And sometimes if you're feeling theirs with your thumb, you're gonna be feeling your own pulse as well. So that's why we use usually the pointer finger and the middle finger. What you're gonna do is you're gonna put your fingers over until you feel kind of a pulse or the area that artery is supposed to be at, and you're going to push down and occlude, actually cut off circulation to that spot, and then just lightly start to release pressure until you can feel the blood flowing through and feel that pulse. And then that's when you start your count. Your temporal artery is up here on either side of the eye, right? And the temporal space, your temples, right? Brachial artery, upper arm, right on the inside, right by the just below the bicep. Radial artery in the wrist, right? We talked about femoral artery in the groin, popliteal artery, the dorsalis pedis, or your pedal pulse, top of your foot, and then you have a posterior tibial artery, but we don't typically take a pulse from that one. The one I didn't list here is your carotid artery up in the neck. Respirations, right? We're breathing, and this is, remember, a breath is not just the intake, but also the exhale. Right? So not just an inhale, but an inhale and an exhale together. Right? So that's one breath. Typically, what you're watching for is the chest rise and fall. And like I said, you're going to usually get your respiration rate at the same time you're doing taking a pulse. So you don't want that patient to know because those respiratory rates get, the patient can kind of, they can control their own breathing, right? And it can be affected by stress, right? They're scared, they're going into surgery, right? Or being scared, that kind of stuff. Exertion, right? Obviously, if you're doing a lot, you're going to be breathing heavier. You need to get more oxygen to your tissues and stuff like that. If there's some kind of metabolic process or disease process going on, that can increase respirations or decrease respirations, right? If you have certain drugs on board, you could be suppressing that breathing. A lot of narcotics, that's the problem with overdose, is that it suppresses your breathing and you pass out, but you're not breathing while you're passed out. And again, you're going to count for 30 seconds and then multiply that by 2. Blood pressure, right? Systolic over diastolic. Your mean arterial pressure. This is the difference between the systolic and the diastolic. So that top number and that bottom number. That number should be around 40 to 60. It's kind of norm. That means that there's enough pressure for when the heart contracts that it's sending that blood to all parts of your body. Right? That means you're getting enough. Perfusion is what it's called. Perfusion is the blood and oxygen getting to your body tissues, because every cell in your body needs oxygen. And the only way that gets there is by blood. blood has to transport the oxygen, in particular, the red blood cells, and even more specific, the hemoglobin on those red blood cells. And each red blood cell can carry 4 molecules of oxygen. It's got 4 places for it to attach to, and then that's it. And every cell in your body has to get oxygen just about every few seconds. Right? Some things affecting your blood pressure, right? Your age, right? Your weight, because if you're heavier, you have more vascularity, there's more tissue. So you need more pressure to be able to get to more tissue. Right? Exertion, how much work have you been putting out? Right? Because your heart's going to be beating faster. If your heart's beating faster, your blood pressure is going to be higher. Right? Or do you under a lot of stress? You got a lot of deadlines on top of you, or a lot of things that you need to take care of, and you don't have a lot of time to do so. Right? You guys remember stress when you were setting up and we were on top of you going, come on, let's go. You got 20 minutes. And now you guys are learning a whole new stress when I scrub in early before your 20 minutes. And then after that, you're feeling strong emotion of, oh, why is he doing this to me? Oh, God, I hate this. Right? Your gender can affect blood pressure. Which gender do you think blood pressure is lower in? Females. Women tend to have a lower blood pressure than men. That's because we're hot-headed. Right? We always get them strong emotion real fast. Right? It takes our blood pressure from 0 to 100 real quick. And then, of course, your ethnicity, your race. African Americans tend to have higher blood pressures. Genetic thing. So, a few different things that affect our blood pressures. Physiologic factors that affect blood pressure. This is your cardiac output. How fast is your heart beating? Stroke volume. This is talking about how much blood is the heart beating out to the body. So we'll try this little experiment too in lab. But let's say you have something that's pumping fluid out, and every time it pumps, right, it's sending the fluid out, and then when it relaxes, it's refilling that chamber, and then pumps again and sends out whatever it refilled. But what happens when you take that chamber and you speed up the pump really fast? Is that chamber going to be able to fully refill before the next pump sends it out? Probably not, as you get faster and faster with that pump. Right? So that's what we're talking about with stroke volume here, is that if you've got a lot of blood in that chamber to pump out, your stroke volume is going to be high. Therefore, your blood pressure is going to be high. It's going to take more pressure on that pump, more effort, more squeeze to get more blood to push through and out. If I have a very little amount of blood in there, there's not a whole lot of pressure it's going to take to push that out. Low volume, low pressure. Your peripheral vascular resistance. A lot of fancy words in there, right? Peripheral vascular resistance. You're like, all right, what's this? What are we really talking about here? So peripheral means far away from the source. The source here is your heart. Right? So the farthest away from the source is, say, your feet, right? Your toes. Well, your toes have blood vessels in them, right? Arteries and veins and capillaries, but they're all real tiny. And if you give some kind of vasoconstrictor, something that makes those blood vessels close up, you've now increased the resistance. You're trying to uh, an analogy or that I can make with this is you ever had like a small balloon, like one of the little round balloons, right? And you go to blow it up and you just go, doesn't take much, right? You just push a little air into it, it starts to blow up, right? Have you ever had one of those really long, skinny balloons and you try to blow into that one? You're like, and you got to blow real hard, and all of a sudden, just the tip of it goes and blows up with air, and you're like, oh, you got to get more air in and blow real hard to get those to blow up. That's that resistance. The little balloon had a lot of area for you to blow into. The long, skinny one, because it was real skinny, you needed more oomph in your blowing to get that to blow up. It's the same thing with pushing the blood into those blood vessels. If they're constricted and closed, you need more pressure to push those open to get blood to flow in there. And the same is true is if you gave a vasodilator and now you've made those vessels dilate real big and open. You don't need a whole lot of pressure to push blood through those. So that's what we're talking about in peripheral vascular resistance. How hard is it for that blood to flow through those vessels? Is that vessel tight and closed off, making it real hard, and now we need more pressure? Or are they nice and wide open, and we hardly need any pressure at all? Okay. And then the resilience of your cardiac and vascular system. What this is talking about is how healthy is those tissues? How able are they to bounce back from being dilated or constricted and going to the opposite, right? Is it going to, and age comes into this as well, right? The older you get, the harder it is for these tissues to bounce back. So your heart pumps, and if you're young and healthy, it pumps and comes right back into shape and pumps again, it comes right back. As you get older, if you've got a disease process going on, right? Say you've got blockage in your coronary arteries. It's not complete blockage, it's a partial blockage, but it's not allowing as much blood, oxygen to get to those tissues of the actual heart, the heart muscle. So you pump, 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 and it kind of slows, right? Because it's not working properly, or it's not an even pump. It's part of it starts to close and the rest of it comes down, right? You're not getting a good push of blood out. That's what we're talking about with the resilience. Taking blood pressures, we did this in the lab, right? We did it with the manual sphygmomanometer, orthostatic or postural blood pressure taking. You're going to take 3 separate blood pressures. Sometimes just 2, but most of the time it's 3. The patient will be laying down. You take a blood pressure, and then you have them sit up on the edge of the bed and let them rest there for about a minute, and then take another blood pressure, and then you stand them up and let them kind of settle in for a minute, and then take another blood pressure. It can change based on, because if you're laying down, all your blood is got to pump up this way, right? When you're sitting up, now it's changed kind of gravity, things like that. So you're going to have different readings based on what position you're in, whether you're laying down, sitting up, or standing up. These can also give us some clues as to what might be going on with this patient. And then when documenting, right, you write the systolic over the diastolic, big number over the little number, right? And it's always in millimeters of mercury. So mmHg. capital H, G, lowercase g. That's how you'll see it written out. Some common errors in blood pressure readings and things like that usually have to do with the size of the cuff. That you've given too small of a cuff to the patient or too large of a cuff. If you give too small, you're going to get false high readings because it's so much pressure on it. If you put on too large of a cuff, you're going to get false low readings. EKG or ECG, the electrocardiogram, these are the stickers we put on the patient, right? So who remembers what color goes on the right shoulder? The white one on the right. Red goes by the heart on the chest, and then the black lead up on the left shoulder. So the way to remember it is smoke over fire and white on the right. But what this is looking at is the electrical activity of the heart, because the heart has the SA node up at the top near the right atrium, right atrium, and then that connects down to the AV node, which is down near the septum and apex of the heart. That electrical impulse that goes through is what gives you the beating of your heart. Right? That's why the SA node is known as the pacemaker of the heart. The electrocardiogram is just monitoring that electrical activity through that nerve. Typically, if you need to do a full assessment on a patient, this is what's referred to as a 12-lead EKG. So typically in the OR, just for monitoring, we're only putting on the 3 leads. But if you need to do like a full assessment of the patient, you need to put 12 leads all along their body. I'm not sure exactly where they all go. But an EKG tech will be the person who comes and does that. Usually those will be done for the patients over in pre-op. But it looks at all the peaks and troughs. You guys have seen the EKG symbol, right? That representation of the heartbeat, right? That's the EKG. Just by looking at where those peaks and troughs and the spaces in between the peaks and troughs, by reading those, you can get an assessment on what's going on with that patient and their heart. Yeah, the QRS waves with the P trough, I think, and the T peak or something. There's a whole when you do, if you become an OR nurse, and trust me, when you guys get out there as a tech and you start seeing some of these nurses that you work with, you start thinking like, how did you become a nurse? Like, I'm smarter than you, and you became a nurse, so I can become a nurse, and you go to nursing school. In the OR, you have to be what's called ACLS certified, Advanced Cardiac Life Support. That whole class is reading EKGs and determining what's going on with that patient. Part of it as a nurse is to be able to recognize that and know what's an emergency, what's not, other than flatline or. But this is where all those QRS waves and stuff like that. Most OR nurses hate having to take ACLS because it's so difficult to look at these patterns and stuff and figure out what's going on, because a lot of them look kind of similar. So you got to be able to know where to pick out your differences. Radiology. I talked about this as being one of your diagnostic pretty much the entire department of radiology is diagnostic, except for interventional radiology, where you're going in and like placing stents and things like that. Otherwise, what we're trying to do is get a picture of inside the patient to see what's going on inside. Right? You got your standard X-rays. You can also do X-rays with contrast, cholangiography. This is us injecting dye directly into the common bile duct and cystic duct to see if there's any stones or blockages. Angiography, we're injecting the contrast into blood vessels to see if there's any stenosis, right, narrowing in certain areas, or there's like plaque buildup and blockages. The way that we can tell that there's a blockage is, say we inject contrast into the femoral artery, and we're at the same time we're taking an X-ray, a C-arm, what's called fluoroscopy, right? So it's constant, because your standard X-rays, you take that one picture, you go get that developed. It's like a Polaroid. Right? The C-arm is like a video camera with the X-ray, right? You just keep the button down and you get to see the whole thing. So you're looking on the outside of the leg and watching the contrast flow through the blood vessels. Well, suddenly the flow stops and you're only like halfway down the thigh. That means everywhere from there down, all the way down to the feet, is not receiving blood. So all of that tissue is starting to die. Myelographies, this is looking at the spinal cord. You can inject dye around the spinal cord and then watch it under like CT scan or MRI and see where it goes. There may be a hole or something in the dura somewhere and it's leaking out, and then CSF fluid is leaking out of there, giving the patient headaches because their brain is low on that CSF fluid. Retrograde pyelographies, right? This is looking in through the bladder, into the ureters, and back up to the kidneys. And the reason it's called retrograde is because all of that flow, you create urine in the kidneys, send it to the ureters, they go down to the bladder out the urethra, outside the body. That's the normal flow, is that way. You're injecting contrast opposite of the way that normal flow goes. That's why it's called retrograde. And then you're looking under C-arm, an X-ray, to see if there's any stones in the kidney or in the ureter somewhere causing a blockage. GI studies, right? This is the where you drink like the barium, and then they watch under MRI or CT as it goes through your intestine to see if there's any blockages or all of that. So all of these are diagnostic. We're looking for some kind of blockage or tear or something that tells us that there's a problem in this area. And then we decide what we're going to do about that problem area. So remember that diagnostics is just looking for the problem. And then we have to decide what we're going to do about that problem. How are we going to fix it? Fluoroscopy, I talked about that. That's the C-arm, right? Same thing, below mobile C-arm. The C-arm is two pieces. There's a big machine, looks like a C. That's the actual functional unit that delivers the X-ray. And then the thing that connects to it that rolls around also is the monitor that goes with it. So then you can immediately see the display of what you took a picture of with the C-arm. CT scanners, MRIs, these are all looking, internal. What these do, the CT scan and the MRI, as they scan your body, they're taking little cross sections from the top of your head all the way down, taking little picture slices each of the way, and then they compile it all in together. So then you scroll through it and you can actually look at somebody from the inside, from the top of their head, and just scroll through, and then you're seeing each little cross section as you go through. So it's a little bit different image than like your normal X-ray where you see bones, stuff like that. Now you're seeing it in just like little slivers stacked on top of one another. PET scans, these are typically looking for like cancer, things like that. Ultrasound. A lot of people, when you hear ultrasound, you think of pregnant women, right? Doing an ultrasound of the baby, but we can do an ultrasound anywhere on the body, just to give us an idea of what's going on inside. And then you have the Doppler. The Doppler uses sound. It's picking up sound wave. And typically what we use it for is we're listening on blood vessels. We're listening for blood flow. Right? You take the Doppler, it looks like a little pencil. It's got a cord coming out of the end of it that plugs into the little speaker box. And then you put that up against an area where you think should be a pulse, right? Radial, brachial, carotid, right? And then just hold it up against there and listen. And you should hear like a, and that should match with the sound of the heartbeat from the anesthesia machine. Every time you hear that beep, 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 you should be hearing a, because that's the heart pumping, pushing that blood through there. If you don't hear anything, that means there's either an obstruction or you're not on the vessel. And they'll move it around and keep moving it around in the areas until they can either find the sound they're looking for, or if they don't find the sound, then they move up with that Doppler pencil until they get to an area where now they start hearing the sound. And then, okay, we need to make our incision in this area. So now we get down, because the problem's got to be here. I've got sound on this side, on the proximal side, closest to the body, right? But I don't have any sound on the distal side, or the side furthest away. So there must be a blockage in here somewhere, right in this area. And you will always hear sound more proximal, because if there was a blockage and I heard sound distal, but I didn't hear sound proximal, there must be another blockage more proximal. And I shouldn't be hearing anything distally if there's a blockage. We'll get more into the Doppler and playing with it and stuff like that when we get into the vascular surgeries. Wait a minute, didn't we already have that? Yeah, we did. This one probably should be deleted. Yep. But blood tests are also a diagnostic tool. This is an invasive, because we actually have to remove blood from the patient, right? We have to stick them with some kind of needle and get blood to come out. But some of the things we can do a complete blood count, right? We're counting the red blood cells, the amount of hemoglobin, right? How many platelets are in there, the leukocyte or white blood cell count. We're looking at all of that stuff, because all of it can tell us something, right? Hey, if you're low on red blood cells, you're probably low on hemoglobin, right? Which means you're low on your oxygen carrying capacity. So we should start to see things like your most peripheral tissues being a little cyanotic or bluish. You don't have that oxygen carrying capacity. You're weak, tired, dizzy. Right? Platelets, we're looking at that. What's your ability to clot? Right? Have you and to form scab and stuff like that. Your differential leukocyte count, or this is what it's talking about, is your white blood cell count. And the differential is what they're looking at is how many immature white blood cells do you have? Because if you have a whole lot of very immature, which means kind of like they were just made white blood cells, you have some kind of infection going on because you already have just a normal amount of white blood cells that circulate your bloodstream all the time. What's happened is those veterans that are on patrol found something and went after it. And the body recognized, hey, we're low on white blood cells. We've used them. Make a whole bunch more. We got a problem going on. That's why you have a whole bunch of immature rookies out there now patrolling. There's a disease, there's an infection of some kind somewhere going on. That's one clue. And then we find other clues and put it all together kind of like a detective. And then figure out exactly what it is that we need to go after. All right, we're going to go ahead and pause there. Let me see. Make sure I got everybody. We'll talk about some teams. Here. Okay. Good. Let's see. This week, the EALs that are going to lock out on Friday will be chapters 10 and 14. The new one that should have opened or should already be open for you guys is chapter 6. The quiz for this week, make sure what I'm saying is correct. Is I believe mostly over PACU quiz 4, right? There's 20 questions on this week's quiz. Oh no, this is over it's over PACU and let's see. I think there's a couple of questions on SPD. Yeah, the 20 questions, I think there's probably about 12 questions on PACU. And then about 3 questions on maybe 2 questions. Everybody write this down. Question number 2 on your quiz. One that asks about which is used to sterilize objects that cannot tolerate the heat, moisture, and pressure of steam sterilization. There's 2 correct answers in the list, but the one that will get you the points is ethylene oxide. Make sure you answer ethylene oxide for question 2. And then there's kind of a few general questions at the end that are kind of about One's dressings. The other one is irrigation fluid. And the last one is about your counts, responsibility of count. So, like I said, on Wednesday, I will release the code for the quiz. After lecture, I'll put it in the lecture chat for you guys. Just keep chipping away at your EALs. And don't forget about your discussion board. First post due by tomorrow night. I haven't heard anything yet on when or if we're rescheduling our town hall meeting. And somebody in group B or C remind me tomorrow to talk to Ortiz about the JOMI to see where we are in the status of it. I forgot to ask him today. He's supposed to be looking into that to find out. Because I know you guys, there's some videos you can only watch for like 5 minutes or something and wants you to sign in. And we thought we had that supposedly solved, but I guess it's not. So, wait. I don't understand, Dee Dee. I don't know what your question is. Oh, what's it? Okay, let me see. That's real nice. Okay, so describe each one of those things: hemostasis, uh, emergencies, post-operative complications, and diagnostic procedures. Just describe each one of those, and that'll be your discussion board for this week. That's ridiculous. It would be fine if I could go in and change it, but deep breath, Mr. Hogan. Deep breaths. You're okay. Does anybody have any questions, comments, concerns? Alrighty, you guys. Have a great rest of your day. Keep working on them EALs. We will see Group B and C in the morning. Well, just B in the morning, C in the afternoon.